Hello, and welcome to the channel. In this lecture, we will be talking about hydrocephalus. The term hydrocephalus came from two Greek words, hydro, meaning water, and cephalus, meaning head. It is a medical condition in which there is an abnormal accumulation of cerebrospinal fluid, or CSF, within the cavities of the brain. These cavities include the ventricles and surrounding intracranial spaces. This buildup leads to distension of the brain cavities, thereby causing too much intracranial pressure, which if left untreated, can cause brain damage, developmental delay, or worse. This damage can be prevented if diagnosed and treated early. Etiopathology. Now, let's understand how this happens. Before we explore the causes of hydrocephalus and how they lead to the condition, let's take a quick look at CSF production, circulation, and absorption. CSF circulation takes place within and around the brain and the spinal cord. It is produced by the choroid plexuses found in the lateral ventricles, the third ventricle, and the fourth ventricle. It flows from the lateral ventricles through the foramen of Monro into the third ventricle, then passes through the cerebral aqueduct of Sylvius into the fourth ventricle. Only a small amount of cerebrospinal fluid enters into the central canal of the spinal cord from the fourth ventricle. From there, it exits via two lateral openings, one on each side, the foramina of Luschka, and a single midline opening, the foramen of Magendie. CSF passes through these openings to enter the subarachnoid space that surrounds the brain and spinal cord, where it provides cushioning, shock absorption, and nutrient. The absorption of cerebrospinal fluid takes place in the subarachnoid space. Here, small specialized protrusions called arachnoid granulations absorb the fluid and drain it into the venous sinuses. This absorption is in equilibrium with its production. Approximately 500 milliliters of fluid are produced and reabsorbed every single day. This delicate, continuous cycle is what maintains a stable environment for your brain and spinal cord. But if this process is ever compromised through excessive fluid production, a blockage obstructing its flow, or impaired reabsorption, it leads to a condition called hydrocephalus. Hydrocephalus can be classified into four major types, each with a different cause. First, hypersecretory hydrocephalus. This rare form is caused by the overproduction of cerebrospinal fluid. The most common cause is a choroid plexus tumor, usually a benign papilloma. In some cases, it can also be caused by choroid plexus hyperplasia, an abnormal overgrowth of the CSF-producing cells themselves. Second, obstructive or non-communicating hydrocephalus. In this type, the flow of CSF is physically blocked, impairing circulation. A classic example is aqueductal stenosis. It can also be caused by infectious processes that lead to scar formation and blockage, head trauma, which can cause swelling or bleeding that obstructs CSF pathways, intraventricular hemorrhage, which is common in premature infants and can form clots that block the CSF pathways. Third, communicating hydrocephalus. Here, there is no blockage in the CSF pathway, and fluid flow is intact. Instead, the problem is impaired absorption by the arachnoid granulations. This is often due to a subarachnoid hemorrhage, infections like meningitis, scarring of the arachnoid granulations, or post-surgical complications. And finally, normal pressure hydrocephalus. This is most common in older adults, where the ventricles are enlarged, but the CSF pressure remains normal. These patients typically present with a triad of symptoms: gait disturbance, urinary incontinence, and cognitive decline, or dementia. Hydrocephalus can also be classified based on the time of onset, as either congenital or acquired. So how does hydrocephalus show up in patients? The signs and symptoms depend heavily on age. In infants, look for changes in behavior and appearance. You might notice poor feeding, irritability, vomiting, or sleepiness. A key physical sign is an enlarged head, as their skull bones have not yet fused. During an exam, a clinician might observe a rapidly increasing head circumference, a tense, bulging soft spot, or fontanelle, and noticeable dilated veins on the scalp. Another classic sign is the sunset eye, where pressure drives the eyes downward, exposing the white sclera. Using percussion or tapping on the skull, especially around the parietal region, may produce a hollow, resonant sound, like a cracked pot. This is known as McCowan's sign. And with a technique called transillumination, when a light is shined against the skull, it can reveal the fluid-filled areas by making them glow. Let's look at the Babinski sign. When the sole of the foot is stroked, the big toe moves up and the other toes fan out. In infants, this is completely normal because their nervous system is still developing. But if we see this same response in an older child or adult, it's a big red flag. It can indicate an upper motor neuron lesion, a type of neurological damage that can be a result of hydrocephalus. Now, for an infant, if the toes curl downward, the typical adult reaction, instead of extending upward, that's actually considered an abnormal finding. It means their neurological development isn't following the expected path. In older children and adults, the presentation changes dramatically. You may see persistent headaches, nausea, or blurred vision. Walking can become difficult, and personality changes or urinary incontinence might also appear. A doctor can check for papilledema, swelling of the optic nerve, which is a classic sign of raised pressure inside the skull. On further neurological assessment, we may see what are known as long-tract signs. These are evidence of damage to the long nerve pathways in the brain and spinal cord. They can manifest as hyperreflexia, where reflexes are overactive, clonus, a rhythmic, involuntary muscle contraction, or spasticity and hypertonicity, which is an increase in muscle tone. All these signs indicate that the nervous system is under stress. So, what do we do when we suspect hydrocephalus? Let's talk investigations. In neonates, with their open fontanelles, a cranial ultrasound is a go-to tool. It's quick, accessible, and effective. While less common now, you might sometimes see skull X-rays used. They can occasionally reveal widened sutures or a copper-beaten pattern on the skull. CT scans are excellent for rapid assessment, which makes them ideal in emergencies. However, they are not as detailed for seeing the dynamic flow of cerebrospinal fluid. And that brings us to the gold standard, MRI. It gives us a superior, highly detailed view of the ventricular system, lets us see the fluid dynamics, and helps pinpoint any potential obstructions. In cases where hydrocephalus might be linked to a genetic issue, such as a congenital or syndromic case, chromosomal studies may also be ordered. Now, how do we manage this condition? While surgical options are the definitive treatment, medical treatment can offer temporary relief in selected cases. A drug called acetazolamide, a carbonic anhydrase inhibitor, is sometimes used. Here's how it works. First, the drug inhibits the carbonic anhydrase enzyme, which plays a key role in producing cerebrospinal fluid. By blocking this enzyme, the process is altered, and the amount of CSF being made is reduced. More precisely, this inhibition decreases the transport of sodium into the ventricles, which reduces the osmotic gradient and ultimately lowers CSF formation. The result is a decrease in CSF pressure and an increase in urination, or diuresis. It's important to remember that the effect is usually temporary. It's best used as a bridge to other treatments, and not as a permanent cure. For surgical treatment, which is the mainstay, the most common procedure is the ventriculoperitoneal shunt. This involves placing a shunt to divert the excess cerebrospinal fluid from the brain's ventricles to the peritoneal cavity in the abdomen, where the body can absorb it. Depending on the patient, alternative shunt placements might be used, such as draining the fluid to the atrium of the heart or the pleural cavity in the chest. An external ventricular drain, EVD, is a temporary measure that diverts CSF from the ventricles to a closed external collection system. Another option is the endoscopic third ventriculostomy, or ETV. This is an ideal solution for obstructive hydrocephalus. A surgeon uses a scope to create a new, clear pathway, bypassing the blockage and allowing the fluid to flow directly from the third ventricle to the subarachnoid space. Sometimes, the treatment addresses the root cause of the problem. For example, if a choroid plexus papilloma is causing the hydrocephalus, surgically removing the tumor often provides a complete cure. Now, it's important to understand the risks involved with surgery. These can include infection, a shunt that malfunctions, or overdraining of the fluid. Because of this, the shunt might need to be revised or replaced later. For these reasons, patients often require lifelong follow-up to ensure everything is working correctly and to manage any potential issues. Ultimately, the outcome depends on a single factor: timing. Catching this early, especially in infants, can make all the difference, leading to a normal, healthy life. But delays can lead to lasting damage. It takes a dedicated team, including specialists in neurosurgery, pediatrics, radiology, and rehabilitation, to change that trajectory. In conclusion, hydrocephalus is more than just fluid buildup. It's a critical breakdown in a system the brain relies on to survive and thrive. Its presentation changes with age, its diagnosis requires swift action, and its treatment, particularly surgery, must be precise. With early recognition, an accurate diagnosis, and ongoing care, the prognosis can be excellent. Thank you for watching. If you found this information helpful, please like and comment. And for more content that can make a difference, hit the subscribe button and turn on the notification bell. We'll see you in our next video.